All right, so we're going to talk today about orthopedic surgery and a lot about lower extremity orthopedic surgery. You know, you can apply these principles to um, total shoulders for sure, but in mind, I had total knee replacement, total hip replacement. Now, when I was a resident over a decade,
Join the meeting.
um, total knee replacements were exquisitely painful experience for patients. I remember patients in agony, 8 out of 10 in recovery room, um, day for days, stuck in bed, very painful surgery. And that's really changed. This is like one of the areas that I've seen a real improvement in our care. So, just a little bit about pain and why it's bad. So, patient experience, that's very important. Certainly, if you're in pain, you're not having a great experience. But beyond that, you really are, you really can suppress your immune system, with cortisol and the surgical stress response. You could actually increase your chances of post surgical infection, poor wound healing. The sympathetic activation increases myocardial oxygen consumption. So you can actually get in a demand ischemia situation if someone's in pain and they're normally 130 blood pressure, but they're 160 all day. Their heart rate's normally 60, but they're 75 all day. And this is more MVO2, more myocardial oxygen consumption than they had prior to surgery, and they could develop ischemia. Plus, it's more shear stress on the coronary plaques. And so all these things increase the risk of perioperative MI. And certainly if you're not having a great experience, if you're in a lot of pain, then you're kind of stuck in bed, and decreased mobility, is definitely associated with more risk for DVT and PE. And, basically we want a good experience. So I want to start talking a little bit. I want to lead off with this topic. So little trivia here. What serious adverse event occurs after surgery with a 6% incidence? So 6%, 1 in 20 people, right? Greater than 1 in 20 people, this occurs to. We don't mention them at all. We'll talk about the most rarest things, like before spine surgery, I'll hear people talking, simple spine surgery, talking about perioperative blindness. And, the incidence of that is so low. The incidence of postoperative blindness from posterior ischemic optic neuropathy is 1 case per 100 spine surgeons per year. So picture, 100 Dr. Amami practices, and one of those surgeons will have a case of blindness in a year's time. And that will probably be in a long case with hypotension, with vascular disease, maybe cocaine, maybe massive blood losses, maybe a 10-hour case. And yet we feel obliged to mention this preoperatively where it's very low risk. But here is something that occurs in 1 in 20 of your patients. So picture we have 20 patients in same day today. One of them will develop this. And what we're talking about is that an opioid naive patient will become a chronic opioid user. So if you have 20 19-year-old knee scopes today in same day surgery, one of them assuming they're all opioid naive. So we're not talking about a patient who comes for multi-level spine surgery who's already on OXYCONTIN 30 TID. We're talking about opioid naive patients. The risk of them developing, becoming a chronic opioid user defined by opioids at the 90-day mark is 6%. And this was, I'm sure you're in disbelief by it. So here's the data. It was a massive cohort in JAMA. And what's amazing about the data is that 80% of the cohort was receiving a minor procedure, your arthroscopy, your cystoscopy, not, like I said earlier, multi-level spine surgery where you might expect at the 90-day mark, there might be a high incidence of opioid use, but 80% of people having, say, a hernia repair who were opioid naive at presentation were on opioids at the 90-day mark. And the people who had even a higher incidence were those that had a mental health disorder, tobacco, alcohol, or substance abuse, people with anxiety and depression, and other preoperative pain disorders like comorbid back pain, neck pain, arthritis, or centralized pain conditions. So the point of these slides is to show that what we're currently doing is not working. We have to change our look at how we approach painful surgery and try to minimize this risk. Now, the initial exposure of opioid also has an impact on how.
Howie.
Hey, Dr. Dress. So,
join the meeting.
Initial exposure of opioid also determines their risk of being on long-term opioids. So, if that initial prescription is for more than 8 days worth, that risk of them being on opioids in the long term jumps up to 13%. And just a little bit more about the scope of the problem. We have 1 million Americans, and this data here on this slide is from 2016, 5 years ago. But $500 billion, 1 million people, 1 million Americans are on heroin. And if you look at this slide, you can see that this is a relatively new and increasing problem. So this is national drug overdose deaths. And you can see in 99 versus 2017, it's gone way up. And if you look particularly at heroin, and the reason I bring up heroin is because 80% of people on heroin started with prescription opioids. So 8 out of 10 heroin abusers started with the misuse of prescription opioids. And if you look back to 1999, there were 2,000 heroin deaths. And, not to scoff at that, that's a World Trade Center amount of people, but it has gone up exponentially. And what you can see with this slide is the reason the deaths have increased is because there's now synthetic narcotics in the heroin. So, if you're a drug dealer and you're trying to bring drugs from Mexico, heroin, you got to fill up a whole truck full. But for fentanyl, you just need a suitcase, right? And so it's much easier to lace the heroin with fentanyl to make it more potent. But the problem is we measure fentanyl down to the microgram, right? We put it in a little syringe and 25 micrograms, 50 micrograms. When the heroin is laced with synthetic narcotics, a lot of times they're, veterinarian synthetic narcotics, carbufentanil, things like that. And they're just kind of mixed up and sent out. And that's why the deaths have really increased. And why did we get to this point with opioid overuse is it dates back to 1986, where there was this guy, Russell Portnoy, published a case series of 38 patients. And that was suggested that non-cancer pain could be managed safely with with doses of opioids without posing a risk of addiction. And a lot of the governing bodies like the American Academy of Pain they kind of bit into this and said, okay, yes, we have to treat pain. Here's some data that you can treat pain without addiction. And it turns out that is all based off of a 38-person look. And before you knew it, the inspecting bodies like JNC and things like that, they were saying that pain is now the 5th vital sign. And if you don't treat pain, you're going to be cited. And this all led to increased opioid use. So the goal of this lecture is to figure out how we can improve pain scores with less opioid, have better patient satisfaction. And we're trying to prevent opioid-related side effects like opioid-induced ventilatory depression, which can lead to, sentinel events. We want to prevent nausea. Nausea is a horrible experience. Patients, when surveyed, would rather have pain than be nauseous. And remember, the PACU is about $1,000 an hour as far as cost goes. And if someone throws up, that leads to a prolonged PACU stay. OSA is a super prominent condition with 1 in 4 men, 1 in 10 females. And if you're snoring at home, you're obviously going to have more hypopnea and apneas if you get opioids perioperatively. So that increases the risk there. And then constipation, decreased mobility, delirium, and obviously dependence is what we spoke about, are other issues we want to prevent. So I like to start with this slide. It talks about pain versus suffering. So all of you are going to go into the holding area and start an IV in a little while. And some of the patients you start the IV on, they're going to just look at you. They're going to continue to talk about the weather or whatever's going on about their procedure and just shrug it off. And you might start an IV at the next bed and the patient, oh, what was me? Oh my gosh, this is so much pain, shrugging and having a bad experience. And so both of those patients had the same pain, but one suffered and one did not suffer. And so the idea is that pain is inevitable. Pain is the afferent impulse to the brain, but the suffering is emotional. It's the response to the pain. It's conscious. And so we can teach our patients about expectations. You know, big part of having an improvement in the experience is to let them know preoperatively what to expect. So you might say something along the lines like, listen, total knee replacement used to be a very painful experience. We measure pain scores out of 10 and it used to be 8 out of 10, but with the approach we're going to take today with nerve blocks and multiple non-opioid medications, we can really reduce that pain. We can bring your pain score down to the 2 to 4 range. And, you know, if the patient wakes up from anesthesia and has a pain score of 4 and didn't expect it, they may expect to be 0 pain. And that expectation will help improve their experience. So we want to talk to the patients preoperatively about our goals. Let them know, hey, listen, we're going to give you a new knee. Your brain's going to feel that. We're going to minimize that pain, but we can't eliminate it, because if we eliminate, we have more side effects of the medications and things like that. But we want to make it a better experience. So, and that brings up like the non-pharmacologic piece, which I used to kind of, you know, not think was super important. But non-pharmacologic involves, you know, teaching the patient how to handle the pain. So like a cognitive behavioral therapy approach of like, whether it be free soul meditation or distraction techniques, like I'm sure you've heard of music therapy, coloring books, telling them to not, you know, if you come out of surgery and you're staring at your knee, it's going to hurt more than if you put your mind elsewhere. Putting ice on that knee. And at our facility, we actually have a holistic care consult where someone will come to the bedside and teach relaxation techniques like breathing, guided imagery, things like that to help not only focus on the medication. Okay, so let's get into the medications. Probably the single most effective medication to minimize pain after orthopedic surgery, and actually this extends to all the other subspecialties. It's been shown in the GYN literature, in the spine literature, in the abdominal surgery literature. Dexamethasone decreases pain. So, you know, I like to make these slides where I just kind of copy and paste the headlines of some key articles just to kind of get that point across that this is a real evidence-based approach. And so dexamethasone reduces length of hospitalization. Now, the hospitals are paid for the procedure, not necessarily how many days you're there. So if you reduce the length of hospitalization, you increase the profitability, but you also decrease the risk of the patient picking up a surgical site infection, having a medical. So length of
join the meeting
endpoint to follow. And nausea, decreasing nausea. Now we know for decades that dexamethasone decreases nausea, but it's just an added bonus now that you get the pain relief. Dynamic pain has been impact of dexamethasone on post-operative analgesia and side effects. So lots of work in the orthopedic literature. Now I want to point out that the dose has to be 0.1 milligrams per kilogram. So 70 kilogram male is 7 milligrams. So we used to give 2 milligrams, 4 milligrams for nausea. That has been shown to not be effective for pain. So here's one of the better studies that have been done, and this is the length of stay study, but I want you to look at, so group 1 was no dexamethasone, and group 2 and 3 were 1 or 2 doses of dexamethasone. And this is the effect of perioperative dexamethasone on distance ambulated, right? So how far can the patient walk after their total knee replacement? And you can see that on day 0, it doubled and went up by a third on day 1 and almost doubled on day 2. And group 3, which got a second dose of dexamethasone the following morning, it didn't add any improvement. So really, you just have to give 1 dose of 0.1 milligram per kilogram of dexamethasone. Now, dexamethasone works on a cellular level with transcribing of proteins, right? So it takes time. There's a latency of onset. So this is not something you want to give in recovery room. You want to give this at the beginning of the procedure. There's like been reports of perineal itching if you give it while the patient's awake, but never seen that. So anyway, 0.1 milligram per kilo for any painful surgery will decrease their pain. And if you look here, this is diluted consumption, right? So if they did not get dexamethasone, they used 4 milligrams of diluted. And if they did, they used 2.5. Now, opioids cause dose-dependent side effects. So if you can almost cut the opioid in half, you're going to have less vomiting, less constipation, less delirium, less sedation, less apnea, hypopneas. So that's a very significant drop. In the PACU, they went from 1.3 to 0.9 on day 0. So this is hydrocodone now, right? So hydrocodone, like Vicodin, the potency of hydrocodone 30 is equal to 20 of oxycodone or 30 of PO morphine, right? So hydrocodone is not a potent opioid. So just so you can understand these numbers. But look at the difference, right? So you went from 15 milligrams of hydrocodone on day 0 to 4. So we're talking about half the opioid. And now if you're a patient, who do you want to be on this chart? Do you want to have a pain score of 5 or a pain score of 2? Right? So this is a significant decrease. And these are randomized trials that showed that dexamethasone massively decreased pain, opioid consumption, length of stay, and increased the distance ambulated. So how does it work? Glucocorticoids limit complement activation. So your CRP and your IL-6 levels are cut in half. Now, what does that mean? Well, there are levels of acute phase reactants and they independently predict pain. So for whatever reason, whether it's sensitizing nociception or working directly on the spinal cord, whatever it is, the drug ultimately reduces these acute phase reactants, which independently predict pain. Dexamethasone also inhibits nerve terminals and synapses of afferent pain fibers in the dorsal horn that are responsible for central sensitization. So central sensitization is sort of that wind-up pathway where, you know, ion channels open and they stay open, and then you get increasing levels of pain. It may prevent that. So I'm sure you've heard the mantra that treating acute pain prevents chronic pain. And so this might be part of that, is that you might prevent that central sensitization. I'm not recommending the 16 milligram, but just so you know that in that study, there was a 50% decrease in peak CRP on the 3rd postoperative day in the study comparing 100. So anyway, more data showing that's effective. And just as an aside, some of us put perineural dexamethasone, but this study, which is a decent size, show that if you give the dexamethasone IV, you will have the same increase in your block duration as if you put it in the block, right? And so dexamethasone is technically neurotoxic, and so there is some debate if giving perineural dexamethasone is completely safe. You know, and it's practiced frequently throughout the nation, so it's probably reasonable to put it perinaturally. But here's some data that show that IV Dex reduced the pain scores, reduced postoperative opioid consumption, improved patient satisfaction, but also improved block duration to a level that was similar to giving it perinaturally. Now, what are the downsides, right? So I can't tell you that everything goes without risk, but the thinking is that this is a safe intervention. So certainly steroids can be immunomodulating, immunosuppressive. So the concern is they could prevent wound healing. They could cause surgical site infection, adrenal suppression, osteonecrosis. So that's the thought, like, could that happen? So one study evaluating the association between steroids and osteonecrosis. So osteonecrosis is like, I guess after you put an implant, you would worry that osteonecrosis could occur. And it really was shown not to occur with one dose in even chronic use if the dose was low. And a meta-analysis, so looking at multiple studies, the perioperative risk of short-term and single high-dose methylprednisolone in surgical patients found no increase in the risk of adverse events. There's no difference in the incidence of wound complications, gastrointestinal bleeding, nor was there one single reported case of osteonecrosis. So I feel comfortable using it based on the currently available data, but I'm always watching to see, with this trend of us using more intraoperative dexamethasone, is there increased risk of patients, or is there increased incidence of patients coming back for, you know, a wound infection or explant? And so far, the consensus is that this is a reasonable intervention with a lot of benefit. The one caveat is in cancer surgery. When you come for a surgical intervention for, say, breast cancer, and you're going to remove a tumor, you're going to have a certain release of cancer cells into the blood, and you want to be as immunocompetent as possible the day of your cancer surgery. You want to be able to scavenge, and now one of the main reasons the cells haven't metastasized is because they're not anaplastic enough to do that. So it's questionable how much impact there is, but the idea is to be as immunocompetent as possible for cancer surgery, and that includes interventions to decrease anxiety, surgical stress. You know, Toradol, Ketorolac has been shown to actually prevent metastasis after cancer surgery, but giving a steroid may not be the best thing for cancer surgery. So that's one caveat I want you to know, that you want to maybe talk it out with your breast surgeon or cancer surgeon prior to giving it in those cases. Let's talk Toradol a bit. So Ketorolac, we're very familiar with it, we're very comfortable with it, but I don't think a lot of us realize how effective it is. So in the literature, it gives you equal analgesia to 8 milligrams of morphine or 100 milligrams of meperidine, right? That's significant. So it's a significantly effective analgesic. And, you know, I remember Dr. Comer teaching us as a resident, and I've seen that data since, that the 15 milligrams is equally analgesic to 30. Now, remember, the side effects from Toradol, which include like decreased GFR, you know, the kidneys sometimes are reliant on prostaglandins to keep the afferent arteriole open if they're diseased. So if you take away those prostaglandins, you theoretically could increase the risk of an ATN. And so by giving less dose, you're probably going to have less dose-dependent side effects, which include gastrointestinal bleeding, bleeding at the surgical site, and potential kidney risk. So if I'm telling you that 15 milligrams is equally analgesic to 30, there's no reason to use 30 anymore. Now, I'll use 30 in my healthy young patients, but I will definitely use a max of 15 in the frail elderly. We want to limit this to 5 days of use, and you want to keep an eye on the creatinine. So the orthopedic resident, you might want to say, hey, listen, creatinine is normal, but keep an eye because they're going to be on round the clock Ketorolac. And it's, if you're going to give CELEBREX, don't give Toradol. It's one or the other. The benefit of Toradol is it's IV, so it kicks in right away. The downside is it's a TID, QID drug. CELEBREX is once a day. So if you give your 400 of CELEBREX preoperatively, they're good till the next day. And we'll talk more about CELEBREX in a minute. And I'm sure you remember that Vioxx was taken off the market, and there was some risk that maybe it interfered with prostacyclin, thromboxane ratios, and maybe led to CAD. So if you look at the package insert for NSAIDs, it says to avoid them in CAD at-risk patients, which is all of our joint replacement patients. So there's a theoretical risk benefit there. You know, so does Toradol cause bleeding? Here's a bunch of studies that shows that it does, right? So we got increased drain output. In mammoplasty, we have tonsil work that shows increased bleeding, some case reports. But then there's a big meta-analysis that says that Ketorolac does not increase perioperative bleeding. So what does it really do in real life? In my opinion, is if the patient is coagulopathic, you know, INR is like 1.6 or something, or they have a history of easy bleeding. Remember, von Willebrand's has a 3% incidence in our female patients. So 1 in 30 patients has von Willebrand's that may not know it. So you always want to get a good bleeding history. Or if you look at the field, you're doing a gallbladder and it's oozy, don't give the Toradol. But if there's no reason to suspect there's coagulopathy or issues with bleeding, then go ahead and give it. Now I have to remember when we make these protocols and we're going to give them round the clock NSAIDs, like what are the risks of it? And so this is a really nice representation. The long lines are the confidence intervals, and you can see the different drugs and their risk of upper gastrointestinal complications. So, you know, this slide just shows it's a no-brainer that CELEBREX is better for your stomach than, say, Ketorolac. So if you have a patient who has a history of, you know, significant gastritis or significant reflux disease with pain, and then you always want to choose the better option for them. So you talk to the orthopedic resident and say, listen, I think this patient would do better with CELEBREX. Now, CELEBREX is generic, it's cheap, it's in our Omnicell in the holding area. It's a great option and it's effective. So you can see that the next best choice is ibuprofen. And naproxen is worse, but Ketorolac is significantly worse than ibuprofen or naproxen. And the dose matters, right? So again, dose-dependent side effects. Here's a look that naproxen high dose versus low dose doubles the risk of gastrointestinal complications. So you want to look at dose finding studies, and you want to say, what is the optimal dose of, say, ibuprofen? It's 400 milligrams, by the way. So giving 800 milligrams is not going to increase your analgesic benefit, but it's going to double your risk of gastrointestinal complications. All right, so let's take a deep dive into CELEBREX, COX-2 inhibitor. So there's less effect on coagulation. It's better on the stomach. But here's the data, right? So there's a 33 to 40% reduction in morphine usage, right? So almost half, well, okay, we'll say a third. We'll say a third reduction in morphine usage. And you decrease your pain score from 4 to 1.5. A 1.5 pain score is very tolerable. So if you can go from 4 to 1.5, that is going to decrease your opioid consumption. It's going to help them sleep better. They're going to have better range of motion, better satisfaction at discharge. So it's a great option. And it comes in 200 milligram. And I usually give 2 pills, so 400 milligrams to my patients without issues. And if they're frail or I'm worried about them, I'll maybe give them the 1 pill. But does it work, right? So this is a study, I think it was ER literature, that showed that CELECOXIB was as well tolerated and as effective as ibuprofen for knee OA. So it's effective and it's safer and it's cheap. Sounds like a no-brainer. And it's once a day. So remember that ibuprofen is every 4 to 6 hours. This is once a day. So I do like this drug. I give this preoperatively, 400 milligrams to almost all my patients. If I forget, I'll give Toradol IntraOp. But I just like the fact that they have 24 hours of coverage. So this was a randomized clinical trial looking at oral CELEBREX 200, CELEBREX 400, and ibuprofen 600. And there was no significant difference among emergency department patients treated for acute pain at 5 hours with CELEBREX 200, 400, or ibuprofen 600. So just more data to show that it's effective and equally analgesic. And again, the Vioxx data, the Vioxx discussion, you know, talked about potential CAD risk. So, you know, risk benefit. It can cause kidney injury, GI bleed. Now CHF, you do get with NSAID some sodium retention. So if someone's really at risk, there's a potential that NSAIDs will retain sodium, cause fluid overload. The sulfa allergy, I don't know if that really ever, there's a sulfa moiety on the CELEBREX molecule, but I don't think it's too clinically relevant. Sort of like our egg discussion with propofol. Most people are allergic to the egg albumin and it's egg lecithin in the propofol, and a lot of editorials really just downplay that relationship. All right, Tylenol. So patients kind of scoff at Tylenol. Say, "Oh, this, that doesn't work for me." And so I just tried to explain to them that it's a piece of the puzzle, that it is another approach to their mechanistically to their pain, and the combination of the drugs that we're going to use is going to bring their pain from an 8 to a 2 to 4. And that's my goal. My goal is for them to be a pain score of 2 to 3. But anywhere 2 to 4 is very tolerable. So plain Tylenol decreases opioid consumption by up to a half. So why would you not use this on all of your painful surgeries for the rest of your career? So before surgery, those little medicine container, you put the pills in, they're like a little cup. I put all the pills in there and I give them a second cup full of water. Because if you give someone a cup, like a styrofoam cup, they're going to drink whatever's in it. But if you give them this small amount in the medicine cup, it's a good way for them not to take too much liquid prior to surgery. And so I make sure I get 3 325s or 2 500s in them before all surgeries, because it's going to cut their opioid consumption in half. Now, you want to schedule it. You want it to be round the clock. And these patients are twice as likely to report excellent satisfaction versus placebo. And here's some work that showed that if you schedule the Tylenol, that they get more Tylenol and that they have decreased opioid use. And so if you see an order, most of your orthopedic orders will say, Tylenol as needed for pain or for fever. We want to schedule it. We want it to be round the clock. You have to stay under 4 grams a day. Personally, I do 975 with meals because I don't want a patient woken up to be given Tylenol. I want them to have 3 doses of 1 gram per day, along with their CELEBREX or Toradol. And those two together are very effective, but I don't want them to be woken up for a scheduled dose every 6 hours. So I personally prefer 975 Q8 scheduled. And as you guys may or may not know, there's an inpatient pain management order in the Cerner that I developed that has this order ready for you to click on. So it will expire in 3 days. So you don't have to worry like, oh, it's a trauma patient and a month from now they're going to come down and still be on Toradol. The inpatient pain management protocol is a 3-day expiration. So here's a really interesting look at if you give the Tylenol before or after morphine. So let's say you forgot to give the Tylenol in the holding area and they're in recovery room and they already got a dose of Dilaudid. They're not going to absorb that Tylenol. So this is plasma concentration of Tylenol. And if you got morphine, it never goes up. It sits in your stomach like a rock. So even though, you'd say, oh, it'll kick in 45 minutes, it's PO, an hour. It doesn't get absorbed because opioids have a significant impact on gastric motility and absorption of drugs. So it's very important to give it preoperatively. All right, let's talk about OFIRMEV. So there is IV Tylenol, and should we be using it? So let's look at this chart, right? So basically, IV Tylenol gives you a higher blood level, but does that matter? And the answer is no, it doesn't translate into better analgesia. So let's look at this graph. Let's say the IV blood level is very high and the PO blood level is not as high, but you can see the analgesic threshold is below the PO level. So it doesn't matter that you get a higher blood level. It matters that you are above the analgesic threshold. So I can show you multiple studies that IV Tylenol is not more effective than PO Tylenol. Here they are. So here's 3 studies, IV versus PO efficacy. And basically none of them translated to a difference in pain. IV versus PO, direct looks. But what is different is the cost. So 8 cents a pill, that's your Tylenol. 8 cents a pill. So 25 cents, we have a gram of Tylenol. OFIRMEV is anywhere from $25 to $60, depending on your, arrangement with purchasing. Now, here's a look in arthroplasty, in orthopedic surgery, that intravenous acetaminophen to multimodal analgesia does not demonstrate significant benefit. I've seen this in my own practice. When I give IV Tylenol, I really don't see the patient's pain improve. I am not impressed. And I was a big advocate to get it on formulary, but there are times I use it. If a patient has an NG tube, I can't give PO Tylenol. And I'm certainly not giving rectal Tylenol. I remember when it was going through P&T, they said, well, why don't you just offer rectal Tylenol? I said, do you really think that if a patient comes in for ACDF and finds out while they're asleep they got rectal Tylenol, that they're going to be okay with that? So IV Tylenol has a purpose. If you need rapid analgesia, PO is going to take too long. That's an option. But only if Toradol is not indicated. So if you have a patient who can't get Toradol, like I had an exploratory lap yesterday with INR of 1.5 and was a little oozy, and I did not want to give Toradol, so I gave intravenous Tylenol. Or let's say surgery is 10 hours and your PO Tylenol preoperatively won't be in the system at the end of the case. That's a time to use IV Tylenol. So NG tube, if the gut's not working, then IV Tylenol is reasonable. Long surgery, it's reasonable. And when you need rapid analgesia, it's reasonable. But there is no benefit to using IV Tylenol over PO Tylenol in patients who don't fall in those categories. All right, gabapentinoids are a controversial issue now. I put up on the left here, this is the most recent meta-analysis. Look, 2020, right? In 2020, a meta-analysis found that the results do not support the routine use of gabapentinoids. But I want to show you a few slides that, I can show you 15 to 20 studies that showed that they do reduce opioid consumption significantly. And in some studies that even show that they decrease pain. So should you use them? And the answer is selectively when they're appropriate. So let's look at some data. They have anticonvulsant, anti-hyperalgesic, anti-anxiety, and sedative effects. And some might even say that the sedative effects, if you're tired, maybe you're not in as much pain because you're sleepy, so maybe it's not a direct analgesic benefit, but for whatever reason, they reduce opioid consumption. So in a look at thyroid surgery and in hysterectomies, 600 milligrams was kind of found to be the optimal dose. So we have in our Omnicell in the holding area, 300 milligram tablets of gabapentin and 75 milligram tablets of pregablin. Gabapentin is 8 cents a pill. Lyrica used to be $7 a pill, but now that it's generic, it's 47 cents a pill. So I used to make the argument that, use gabapentin because it's only 1 hour delayed onset, meaning it's not far inferior, but it's much cheaper. But now that they're on an equal playing field, they can be used interchangeably. But there is more work done with the gabapentin in the literature. And just so you know, 300 milligrams has been shown to be effective. So if you have someone who's frail or OSA, don't use gabapentin. But if someone's between frail and normal, and you don't really want to give them 600, 300 is efficacious. But personally, if I have a rough and tumble patient, good shape, not frail, not OSA, and I'm worried about their pain postoperatively, I'm giving them 600 milligrams of gabapentin. It will decrease their opioid consumption intra-op. If you don't decrease the opioids you normally use, you will have a delayed wake up. So gabapentin, if you use it, you have to use less intraoperative opioid and plan your wake up a little bit earlier because it will lead to, remember the OR costs $60 a minute. So every minute you have a delayed emergence, you're causing lots of cost. So you have to plan by using less opioid because they are slower to wake up. And look here, there's a bunch more data to show that it's effective. Now, pregabalin versus gabapentin, right? So most of the studies that have examined the preoperative administration of gabapentinoids have been administered between 1 to 2 hours before surgery. It's reported that the time to peak plasma level after oral administration of gabapentin in humans is 2 hours and 1 hour for pregabalin. So better pharmacokinetics. It may be equally analgesic, but a better bioavailability profile. The other thing is, it's not so much a blood level, it's a cerebrospinal fluid level, and that takes about 8 hours. And that's why you could see a lot of programs would give the first dose of gabapentin the night before. But I don't do that. I'd give it the day of surgery with a sip of water with their CELEBREX and Tylenol in the right patients. I don't give it to all patients. But if I have a patient on Suboxone, you better believe they're getting it. If I have a patient who's on chronic OXYCONTIN, you better believe they're getting it. If I have an extraordinarily painful surgery and they're not sleep apnea, I hope I'm being clear. Do not use this drug in sleep apnea patients or frail patients. They're getting it. So how much should you use? 300 or 600 of gabapentin and 75 to 150 of pregabalin. 150 is probably equally analgesic to 600 of gabapentin shooting from the hip. All right, again, just more look at data. I know this recent meta-analysis showed no benefit, but it's hard to argue with all of this literature that consistently shows 30% decreased opioid consumption. And just so you know, that 1,200 milligrams preoperatively is not more effective than 600. So in dose-finding studies, one dose of 600 or one dose of 300 is effective, 6 more than 3, and it is not necessarily more effective to continue it postoperatively. So I just do one dose, one and done. But remember, 30% of people report oversedation, and in the 150 BID trial of Lyrica, which is a big dose, 5% of people got confused. You don't want confusion. Confusion at 2 a.m. equals a stroke code in a CAT scan. And it's not, we don't want to deal with it. We want to set it and forget it policy. And so that's why one preoperative dose in the right patient is the way to go. All right, now here's the efficacy of preoperative administration of gabapentin pregabalin improving pain after hip arthroplasty. Pregabalin can decrease cumulative morphine consumption at 24 hours. In spinal surgery, total morphine consumption was significantly lower over 24 hours post-operatively in the gabapentin group. More spinal surgery. Adjuvant gabapentin exposure was defined as at least significantly lower mean pain scores post-op day 1 to 3. Meta-analysis in spine surgery, gabapentin associated with reduced pain for 6, 12, 24, 48 hours. Similarly, gabapentinoids were associated with reduction in cumulative morphine consumption 24 to 48 hours. Spinal fusion patients, CELEBREX plus gabapentin had significantly lower pain scores postoperatively. Posterior spinal fusion, preoperative gabapentin and Tylenol, intravenous, reduced pain, faster mobilization, reduced frequency. All right, a little bit more about pregabalin. So 5 trials with 6 treatment arms used periop pregabalin at a dose of less than 300 milligrams per day. Pregabalin was administered before operation, as in one dose in 4 trials. So 4 of the trials just gave one dose, didn't continue it postoperatively. And I wanted to show that there is data that 75, because you don't want to use something if it's not efficacious. So 75 milligrams that was shown in this trial to be effective, but 150 is probably more bang for your buck in the right patient. All right, I'm going to restate it again. Patients you're worried about postoperative pain, very painful surgery. Patients on preoperative Suboxone or history of substance abuse. Patient on chronic opioids that are not frail and do not screen positive for OSA, so their stop bang is less than 3. Definitely less than 5, but less than 3 is better. Those patients are candidates for single dose gabapentinoids preoperatively, as long as you make an adjustment in your intraoperative opioids. I think I'm harping on this a little much, so I'm going to I sent this presentation out to look at this data more closely. Okay, PCA, really don't use it anymore, but there are certain times you might use it. The idea is with PCA was that analgesia occurs at a lower dose than sedation. So by giving frequent small doses, you could decrease the level of side effects. The downside is you're attached to a pole. So it decreases more motility, and it increases length of stay because people aren't advanced as quickly. So it's not a standard routine treatment anymore in our current situation. Same with OxyContin. So OxyContin has tremendous stigma, and patients may actually be offended if they find out that they were given it. But there are certain patients where you may want to give a 10, right? So a 10 of OxyContin is 2 Percocet, right? So 5 of oxycodone, 20 of oxycodone is equal to 10 of IV morphine, right? So 10 of oxycodone is equal to 5 of IV morphine. So giving 1 OxyContin is like giving 5 milligrams of IV morphine. And it's a 12-hour drug. Some would argue more 8, but it's a 12-hour drug. So if you gave 1 dose at 7 a.m., they would have the equivalent to 2 Percocets in them all through therapy throughout the day, but they wouldn't have the sleep effects at night. But again, this is really not something we're doing, but select indications, select patients, you may order OxyContin 10 QAM. And it's good to have a holding parameter. Hold for a POS score greater than 2, hold for a failed respiratory assessment. I haven't written for this in a long time, though, to point that out. A little bit about ketamine. So any chance you get in any painful surgery, squirt some ketamine at the patient. I can show you data for days that giving intraoperative ketamine will improve postoperative pain scores. And one of the biggest trials was out of Dartmouth. Took 100 painful spine surgery patients, and it gave them 10 mics per kilo per minute of ketamine intraoperatively, stop at skin closure. So you figure about 40, 50 milligrams an hour. And what it found was this 45-minute drug decreased opioid consumption 48 hours later. So the drug's completely out of their system, but it still decreased opioid consumption when it was out of their system. So it prevented central sensitization and windup. So ketamine at a dose anywhere from 2 to 10 mics per kilo per minute. So 2 mics per kilo per minute would be about 10 or 15 milligrams an hour. 10 mics per kilo per minute would be 42 milligrams an hour. So anywhere from 10 to 40 milligrams an hour. So what's an easy way to do that would just be to give 20 milligrams every half hour, right? So you don't have to get a pump together and everything. Just give 20 milligrams every half hour, maybe cap it at 150 or 200 in a long case. But if you do that, they will have 30 to 40% less opioid consumption perioperatively. Now, personally, I like to give, when I'm sedating a patient after spinal, I'll have some propofol running. I'll give, say, 10 milligrams of ketamine IV periodically, which will keep them snoozing, because ketamine is a very potent analgesic, but at high doses is a hypnotic. But if you give 10 milligrams, we call it ketofol, sort of like propofol and ketamine together, and it decreases your propofol dose. And by decreasing your propofol dose, you will have less airway obstruction. It's also very useful when you're going to put your spinal into an elderly patient who has a hip fracture. I'll give like 2 cc's of propofol and 10 milligrams of ketamine. And that will give such potent analgesia, you'll be able to put them on their fracture side down to put the spinal in. But here's a bunch of studies around arthroplasties that show that when given intraoperatively, there's a postoperative opioid sparing effect. Now, ketamine can cause delayed awakenings, hallucinations. It has to be used appropriately. So talk to your attending about how it can be used prior to playing with it. Just another look in anesthesia analgesia, the early and delayed analgesic effects of ketamine after total hip arthroplasty. So sometimes it's used on the floors. Now, you can't just write for ketamine on the floor at St. Joseph's because you need a policy in place. what monitoring is needing, what do you do with an overdose, what the infusion rate should be. So just to let you know that in certain situations, ketamine is run postoperatively at say 2 mics per kilo per minute to help with really painful situations. So this is our protocol at St. Joseph's, and we put our patients into 4 categories. Normal risk, so that's your healthy person, right? They were playing tennis, their knee now hurts, and they need a joint replacement, but they have no real big comorbidities. We would not want to give the doses of Toradol, Gabapentin, hydromorphone. We would not want to give the doses we give to that person to the lady to his in the next category, the frail category. So by having categories, we give the right dose to the right patient. So we have 4 categories: normal risk, frail, OSA, and dialysis patient. All right, so here is our preoperative. So this is what you can give preoperatively in the holding area to our patients. We can give CELEBREX or Toradol. Now, Toradol is usually given towards the end of the case because of multiple reasons. But if you're going to give preoperatively, you would give grandma 200 of CELEBREX, but you would give the weekend warrior 400. CELEBREX is not used in dialysis patients. Neither is Toradol, but ibuprofen surprisingly can be used in dialysis patients. And the OSA patient, we really want to push the NSAIDs. We really want to push the Tylenol, but we want to not use Gabapentin in the frail or the OSA at risk. And if someone's high risk of nausea, right? So if they're female, young, history of post-op nausea, vomiting, history of motion sickness, you want to slap on a scopolamine patch. Scopolamine patches take an hour to kick in and they last for a day. So you just tell the patient to leave it on, but when they take it off, to wash their hands, because if they touch it and touch their eye, they can get hemodriasis. And if they get dry mouth or urinary retention or dry eye, they can take it off. All right, now post-operatively, we want them to get the NSAID, the Tylenol, and plus or minus the dexamethasone. I think our orthopedic residents do give a post-op day 1 dose, but I showed you in the one trial that wasn't really effective. Now, this is all opioid sparing, but it's not meant to be 0 opioids, right? If we can cut our opioids from here to here, that's a win. But I'm not saying they're not going to need any. So you have to have something for breakthrough. So oxycodone 5, but did you know that we have a suspension, a liquid oxycodone at our hospital? So if you have a little grandma broken hip, she's 50 kilos. Does she need 5 of oxycodone? No, 2.5 of oxycodone would be great for her. So the order might say for a pain score greater than 7, right? So in other words, we don't want to give opioids for mild, moderate pain, but for severe pain, we want to give it. You can give 2.5 milligrams suspension of oxycodone. And this is all in our computer, in our Cerner. You just type inpatient pain management protocol or any of those terms, it'll search up, choose the frail elderly column, and you can give these smaller doses. So tramadol is kind of caught on because there's less stigma. Maybe there's a ceiling on respiratory depression, and it certainly has its downsides with multiple drug interactions. But you see more use of it. The orthopedic residents were using a lot of it, and that's why I included it in the protocol. I'm not really advocating for it, but so you know, 50 would be like a decent dose for a regular person, but you might want to cut back to 25 in the at-risk patient. Now, dilaudid 0.5 milligrams is equal, so 1.5 of IV dilaudid is equal to 10 of morphine. So it's roughly 7 times more potent. So 0.5 milligrams of IV dilaudid is equal to 3.5 of IV morphine. That is a very nice, safe place to start in everyone except super frail. So super frail grandma might get a 0.3 milligram of IV dilaudid, but 0.5 is a very decent place, 3.5 of morphine equivalent, to bring the pain score from a 7 to a 4. We're not trying to get to 0 and be unconscious and snoring. We just want to reduce the pain score. And some people like morphine. I personally choose dilaudid. It's more a little quicker onset, a little more lipid soluble, and but morphine, 2 to 4 is a good place to start. Now, if someone has chronic sickle cell disease and they've been on 2 milligrams of IV dilaudid around the clock, that's a different story. But remember, 2 milligrams of IV dilaudid is 14 of IV morphine. Would you ever write for 14 of IV morphine? The answer is no. So why would you write a more lipid-soluble drug, 2 milligrams? So 2 milligram of IV dilaudid is a very dangerous order for all comers. And yes, it's appropriate in certain situations, but you may want to educate your medical colleagues about the equal potency dosing that we talked about. All right, so we're running out of time, but I'm going to keep talking. And this will be recorded and on our YouTube channel, so come back to watch it if you have to go. I'm going to keep going. So we'll talk about local infiltrative analgesia versus a peripheral nerve block. So LIA is what the surgeon does in the field. They're injecting different parts of the knee with local anesthesia versus us doing a nerve block. I'm going to talk about the pros and cons of each technique. Now, just to start off, epidurals used to be used for joint replacement. Well, the initial data show that the peripheral nerve blocks were equally analgesic to epidural in some of the work. And so that allowed the nerve blocks to start being done. So what's done? Fascia iliac nerve block is a block we're going to talk about. The femoral versus adductor canal block, the sciatic nerve block, the IPAC block, and then continuous versus single shot nerve block. So here's the fascia iliac nerve block. Now, I do not routinely do the fascia iliac nerve block for hip arthroplasty because it causes 100% quad weakness, 0 out of 5 quad, 100% of the time. Our patients are walking in recovery room, and it's not good for all comers. But there are select patients, maybe they have a history of opioid substance abuse, high dose opioids at home, very scared of pain, where you might make an exception. If you do, though, you have to tell the patient their knee will buckle when they walk with a therapist. I have seen falls, and falls happen every day from femoral nerve blocks. Even adductor canal blocks has a 1 in 20 risk of quad weakness, and fascia iliac nerve blocks. I do use this block selectively after hip scopes. So typically a young patient who has a lot of anxiety, who has a labral tear and is crying in recovery room, I will go over to a fascia iliac nerve block. The fascia iliac will get the femoral nerve, which will get all the osteotomes to the femoral head and neck. It will also get the lateral incision of the lateral femicutaneous 80% of the time, and it will make their pain go away. So it's a great rescue block. The fascia iliac nerve block is a great rescue block for hip surgery, but you have to take the caveat that it will cause quad weakness, and you have to educate, talk to the surgeon, talk to the patient, give a nursing communication order to let them know there'd be quad weakness, because these patients usually don't have a leg immobilizer on. So what we do is there's 2 ways. You can hold the probe like shown in this picture. You go through the fascia iliaca, right? And so let's look at the upper left picture. We have the iliacus muscle and the psoas muscle. The psoas is a hip flexor. The iliacus and the psoas come together to form the iliopsoas. And on top of them is a very thick membrane called the fascia iliaca. If our needle tip is under the fascia iliaca, we put 40 to 50 mLs, it will spread to get the femoral nerve and the lateral femicutaneous. And so you can approach it in this manner, but an easier way, and just so you know, this is the internal oblique muscle and this is the sartorius muscle. They call this the bow tie sign. The middle is the inguinal ligament. So sartorius, cephala is the internal oblique. This is the iliac muscle over the ilium, right? If you follow this to the ASIS, that's more lateral, more medial. This is the ilium. This is all muscle. Our needle will pop through the fascia iliaca here. We'll put our volume and we'll get the femoral nerve and the lateral femicutaneous. But an easier way, and just to show you, this is the fascia lata, fascia iliaca, femoral sheath. These are over the muscles, and the pop you feel is just like when you do an epidural and you go through the flavum. Quick video. So here's a needle going through the sartorius, popping through the fascia iliaca. And as he injects, we do what we call hydrodissect. Hydrodissection is where you lift the fascia iliaca up off of the iliacus muscle, iliopsoas muscle, and you're going to get spread to the lateral femorocutaneous and spread to the femoral nerve. You do not get the obturator nerve like traditional techniques of lumbar plexus block. A much simpler technique is to hold the probe like you're doing a femoral nerve block, go through the sartorius muscle. So here's 3 views of when you're holding the linear probe over the leg, right? So more medial, you'll see the artery, femoral nerve, iliopsoas, fascia iliaca, sartorius muscle. I bring my needle through the sartorius muscle, pop through the fascia iliaca, lift up the fascia iliaca off the iliopsoas muscle, and get spread to the femoral nerve and to the lateral femorocutaneous. And you can see if you brought the probe more laterally, you see the tensor fascial lata muscle and the sartorius. So you move medial till you see the artery and nerve, move lateral till you see the sartorius, go through the sartorius, pop through the fascia iliaca, and put 40 to 50 mLs of dilute local anesthesia, meaning 0.2 ropivacaine, 0.125 bupivacaine, or 0.25 bupivacaine, be fine too. All right, so femoral nerve versus adductor canal block. So quick word on the femoral nerve block. I very rarely do femoral nerve block anymore. Maybe in a quad tendon rupture because they're not going to be ambulating anyway. But if I injure the femoral nerve, which I do know of a case report where that occurred at a local hospital, there's a dramatic consequence, life-changing consequence. If I do an adductor canal block and I damage the saphenous nerve or the nerve to the vastus medialis, patient's probably not even gonna have disability. So one reason to stay away from femoral nerve block is the risk of nerve injury. The risk of nerve injury is about 3 in 10,000. So you have to ask yourself, will you do 3,000 blocks in your career? And if you do, it's in the statistics that you're going to have nerve injury. So I prefer to go distally to prevent injury. And of course, hearing this story that happened at a local hospital changed my practice. But I want to get that point across. So the femoral nerve has anterior and posterior divisions. The posterior divisions go to the deep muscles and the osteotomes, and the anterior divisions form the saphenous. So we want to block the femoral nerve proximal to where the deep and superficial femoral artery bifurcate. Because when you have a femoral artery, the nerve is all together like my wrist. So you have fingers being the divisions and the wrist being where the femoral nerve is all together. So I want to see the bifurcation of the deep and superficial femoral, come proximal until I see the femoral artery, then move the probe laterally until I see the femoral nerve, pop through the fascia iliaca and inject. Now you don't want your needle to touch your nerve. You want to be perineural. You never want a nerve to expand with local. You want to be outside the nerve. So that's the talk about femoral nerve. Now, here's a bunch of data I found that showed that the adductor canal was equally analgesic to the femoral nerve block. So if you have something that's going to cause less quad weakness. Now, Jager, the bottom study, she did a lot of the work with muscle weakness and found that 1 in 20 people got weak quad. So you still have to warn your patient that the knee could buckle. And the possibility for quad weakness is there, but it's much less because it's 100% quad weakness with a femoral nerve block, if you do the block right. And it's 5% with the adductor canal block. But here's some data that show that the adductor canal is equally analgesic to the femoral nerve block. Now, for total knee replacement, the femoral nerve is responsible for 65% of the pain. So you can take away 65% of the pain with this intervention. But remember, the patient still has the other 35% of pain. And to them, it's 100% pain. So it's important to tell them what I did here really reduces the amount of pain you would have had. And they can take some solace in that. They still have pain, but it's much better than it would have been. Now, if you do the IPAC block, That's the other 35%, except for the posterior branch of the obturator. Internal branch of the obturator. All right. Okay, so adductor canal block. We have 3 compartments to the thigh. We have the anterior compartment, that's your quad muscle. We have the posterior compartment, those are your hamstrings. And we have the medial compartment, those are your adductors. The adductor canal is it's below the sartorius, first of all. So the sartorius, like an external rotator. If you lift up the sartorius, you're looking in the adductor canal. And on the medial side of that is the adductors, and on the lateral side of that is the vastus medialis. And inside this adductor canal or Scarpa's triangle is basically the saphenous nerve, which is anterior divisions of the femoral nerve, a nerve to the vastus medialis, which is gives some genicular fibers to the knee joint, so it does help with pain. And the superficial femoral artery and the vein. I like making these kind of slides where you can kind of see everything. Probe position, needle placement, drawn out anatomy. Neuraxium.com, I think, is where this is from. Ultrasound shots and a close look at the canal here. So quick video. So we have the artery here. Next to the artery is nerve. Now this needle is inside. It hasn't popped in yet, but now it's inside the sartorius muscle. If you inject there, the block will not work. You have to advance until you leave the sartorius muscle. So still the needle is inside the sartorius muscle. And now you're going to see a pop. That pop is him leaving, or her leaving the sartorius muscle and being perineural next to the saphenous nerve and the superficial femoral artery. As you inject, you'll create a space with hydrodissection. You want to aspirate to make sure you're not in the vein or artery, and you want to make sure the patient has no pain on injection, because you don't want to be intraneural. Now remember, our block needles are blunt. Like you take a 25 gauge needle out to put local in, that's a very small angle. Our block needles have a less steep angle, so they kind of push nerves out of the way. They don't pierce nerves. That being said, it's always possible. So you want to make sure when you inject, so you aspirate, you have the nurse or whoever's injecting use their thumb. 2 fingers to inject is a bad idea because it creates a lot of pressure. It's been shown that you will not cause nerve injury if you're under 25 PSI pressure. So 1 thumb, it should feel sort of like butter. If not, you're probably on a fascial plane or intraneural. So you inject in incremental dosing, just like an epidural, and you want to see spread on the field. If local is spreading on the field, you know it's not going in a vein, or if you're doing interscalene, it's not going intrathecal because you're seeing spread on the field. So you want to see your needle tip, your target, your spread on the field. If you have those 3 things, ultrasound becomes a very safe way to do the nerve block. This is a dye study that just showed that when you inject here, you get spread up and down the canal. It's not so important exactly where you are. Usually where I'll go is above where they ace wrapped it, but there's caveats about going more distal and versus going more proximal. So a true adductor canal block versus a femoral triangle block. All right, let's talk about IPAC block. So fairly new, a couple years now, but it stands for infiltration between the popliteal artery and the capsule of the knee. And the idea is that you're going to get all these fibers shown in this picture that are going to the posterior capsule. So with the adductor canal, we got all the femoral osteotomes from the anterior divisions of the femoral nerve. So all we're missing is some of the obturator, the posterior branch of the obturator, and the branches that come off of the tibial nerve. So what we do is we put our needle between the vessels and the bone and inject on the way out to get all these little branches. So you put the patient in what's called the frog leg position. It's best to put a rolled blanket under the thigh. And you look, you start here and you look at the femur. And you see the nice bone and arteries over here. the same artery we just talked about in the adductor canal. Then you slide the probe caudally until you see the condyles form. And really you want to be proximal to the condyles, more at the metaphysis. But you want to make sure your needle goes between the bone and the artery and vein. And you inject 10 to 20 mLs on your way out of whatever, Exparel and Bupi or just Bupi, whatever it is. And it's very effective. The benefit here is you usually, as long as you don't accidentally get the common peroneal nerve, you usually don't get foot drop. When I was a resident, we would do popliteal block for total knee arthroplasty, but there was a foot drop. And it would drive the surgeons nuts because especially in a valgus knee, there was a 2% chance of stretching or damaging the common peroneal nerve, causing a foot drop. And so foot drop, it delays rehab, and it makes the surgeons nervous that there could be a surgical injury. So foot drop's not acceptable anymore. So I might do a popliteal as a rescue block in someone who's got a lot of pain after I talk to the surgeon and evaluate dorsiflexion of the big toe prior to doing it, right? If there's no dorsiflexion of the big toe before my block, there could be surgical injury. And the last thing I want is post-op day 3, a patient with foot drop thinking it's from my popliteal block. So if I document that there's no dorsiflexion of the big toe, I'm not going to do the block because of double crush risk, right? There's already injury to the nerve. So if I injure a few more axons, which normally would be subclinical, it may be very dominant presentation. So I wouldn't block if there was injury, but if I show there is dorsiflexion prior to my block, then I know that it wasn't a surgical injury if it does occur. So there is a case in the literature of arterial injury during an IPAC block. So make sure you see your needle tip and that you don't touch the vessels. So you want to go between the bone and the vessels and inject on the way out. You cannot do this block post-operatively because the metal or whatever, titanium or cobalt, whatever they use in the joint isn't going to prevent your view with ultrasound. All right, popliteal block we'll save for another day, but you know, in brief, we usually do it right around the bifurcation. You know, we have endoneurium, perineurium, epineurium. Well, what's around the sciatic nerve at the 6 inches above the knee is called paraneurium, and it's a stroma. And we enter it, but we make sure that we're between the common peroneal and posterior tibial before injection. We never want to inject intraneural. And I always use a twitch monitor to show no twitch at 0.4. So if there's no twitch at 0.4 milliamps when I inject, I'm unlikely to be intraneural. And furthermore, if there's no pain on injection, that's more evidence that I'm not intraneural. So if I document that I had a patient awake, I used a twitch, I had no twitch at 0.4, and I had no paresthesis on injection, and I saw needle nerve visualization throughout the block, I'm less likely to be found by a jury of my peers to deviated from standard of care. And if there's nerve injury, which thankfully I haven't had, but if there's nerve injury, I say, listen, there's inherent risk to the procedure. I explained the risk to the patient. The patient accepted the risk, and I did everything in my power to minimize that risk. Meaning, I showed there was no twitch. I showed there was no pain on injection. I saw the needle tip and the nerve throughout, and I saw spread. And there's a lot at stake with this because a foot drop causes a lot of disability. But anyway, this is the position I like to do popliteal nerve block in. I'll have the patient reach for the bed rail, and as they do that, I'll pull the draw sheet under them to get them on their side, put a pillow between their knees. Start at the popliteal fossa, see the popliteal artery. That'll help me find the posterior tibial nerve. Then I'll scan up until I see the common peroneal joint it. Now, if you do the block mid-thigh where the sciatic nerve is together, it's really hard for the local to diffuse to the deep parts of the nerve. And you may have, even though you have a donut sign around the nerve with local, you may have inadequate analgesia. This happened to me at a surgery center. I had perfect spread around the entire nerve and patients still had pain and recovery. So now I go to the bifurcation. I go between the common peroneal and posterior tibial, and I inject without pressure or pain 20 to 30 mLs of local, and I get much rapider onset. All right, LIA, local infiltrative analgesia, done by the surgeon. So this is effective, but with plain local, it really only lasts 6 hours. That's kind of what the data surmised. So whether or not mixing Exparel increases that hasn't really been shown. In fact, one study showed it didn't improve the duration, but it's advisable to do LIA. So Karen Cohen brought it to attention. They used a mixture of ropivacaine, Toradol, epinephrine. And what they do is they make it to 120 mLs. And they put some subcuticular, right? So in the incision. Then they go at the level of the arthrotomy. They inject in the medial retinaculum and the quadricep tendon. They put 10 mLs in the suprapatellar fat pad. They inject some periosteally. And they do this throughout the procedure as they're going along. And then once the bone cuts are made, they go into medial meniscus scar and then into the posterior capsule. And so this is called local infiltrative analgesia, and it can also be done for hip surgery. And it's effective. And the question is, how long does it last for? What's important is if your surgeon's going to do it, that you make sure you don't overdo the local. And I'll frequently add an adductor canal block to their LIA technique or an IPAC block and just use some 0.25%. Remember, you can use 30 to 40 mLs of 0.5% ropivacaine or bupivacaine, 30 mLs for sure. So if you cut that dose, same dose, but you double that volume by adding saline, you now have enough to do your 2 blocks or whatever you need to do. A little bit about Exparel. So when using bupivacaine with Exparel, you can't use more than 133 milligrams of bupivacaine, right? So in the Exparel bottle, there's 266 milligrams. And remember, 0.25% bupivacaine is 2.5 milligrams per cc. So as a reference, 50 mLs of 0.25% and 25 mLs of 0.5% equal 125 milligrams. So you have to make sure that you don't use more than that volume when Exparel is used. All right, let's keep going. So neuraxial versus general. If I'm having a knee replacement, I'm getting a spinal. So that's what I tell my patients. If you were my mother, I would recommend a spinal because you'll have less total opioid consumption while in the hospital. You'll have better overall pain scores. You'll have a much better PACU stay. You'll have less nausea, vomiting because there's no emetogenic drugs used like volatiles. Your length of stay will be decreased. Your wound infection risk will be decreased. You'll have a decreased risk of DVT and PE. You'll have a lower transfusion requirement. And that has to do with venous capacitance, but also when your mean arterial blood pressure is lower, you have less hydrostatic force to push blood out into the surgical field. So a lower mean arterial blood pressure has always been shown to decrease intraoperative blood loss. And that's why epidurals are used for big hip revisions, because they decrease blood loss, as well as other good things. Respiratory depression, facilitated rehabilitation. Overall mortality of patients with neuraxial was also reduced by approximately 1/3 compared to those who received GI. And in the obstructive sleep apnea patient, there has also been shown a mortality benefit of getting a spinal over general. So how much did you use? Personally, I use 0.5% isobaric bupivacaine from 2.2 to 3 mLs. The higher you go, the longer it's going to last. When I was a resident 12 years ago, we used much higher doses and we had corresponding more high spinals. I would say my average dose is 2.6 cc's, but I do base it on the vertebral length. So a short patient might get less, and a longer duration, I might use a higher dose. Certainly a frail gamma nail might just get 2.2 cc's. Should you put astromorph in your spinals for arthroplasties? I would say it's probably not standard. It's a risk-benefit decision. Always should be talked out with your attending. But if you do, the dose finding studies show that Knees need more than hips, but the range is between 100 and 200 micrograms. Now, there's never been in the literature that I'm aware of an incidence of respiratory depression when less than 300 micrograms has been utilized. So when I use 150 micrograms, I'm pretty confident that it's not going to cause respiratory depression. And remember, respiratory depression with fentanyl might be 20, 30 minutes later, but with a hydrophilic morphine, it might be 6 hours later, but as late as 24 hours later. So whenever I use intrathecal opioid, I put a communication order in that has the patient observe the patient for advancing levels of sedation, advancing POS score, or changes in the respiratory assessment. And one way you can do this is when we write for a PCA, there's a certain protocol that the nurses follow to document the POS score and the respiratory assessment. And so you can have them follow that. So you show in your record that you did what you could to be safe. Because if there's not advancing levels of sedation, it's very unlikely to have an event based around delayed respiratory depression. I do remember one time I used it and the patient in recovery was just moving their knee around like they didn't have surgery. They had zero pain. It was very impressive. You know, I think the verdict's not in. It's certainly risk benefit, and you have to have perioperative orders for monitoring if you do utilize it. One quick talk about carbohydrate drink, because I know you're all seeing this. So fasting after midnight was commonly utilized because it was easy to tell a patient, just don't eat after midnight. And it just made intuitive sense that if you gave less before surgery, there was less likely for aspiration. But it turns out that it led to patients being anxious, irritable, hangry. It actually decreased glycogen stores where they had to go after their skeletal muscle for nitrogen. So there was skeletal muscle loss. There was more ileus, more post-op nausea, vomiting. And so the thinking now is to give an oral carbohydrate drink up to 2 hours before surgery. And just so you know, this is nothing new. If you look at our ASA guideline on the preoperative fast, it has always said for normal healthy people to take clear liquids up to 2 hours before surgery. But remember, if a patient has the stigmata of type 2 diabetes and has delayed gastric emptying, you know, they're burping up last night's spaghetti and the next morning, they're not a candidate for this. So you have to always use your clinical judgment if it's appropriate or not. But tons of data to show that a 50-gram carb load 2 hours before surgery improved nitrogen balance, ileus, and satisfaction. So if you're going to do a marathon tomorrow, are you going to starve yourself? No, you're going to carb load. And so the idea is you take 100 grams of carb night before and 50 grams the morning of surgery. I prefer it to be 4 hours before surgery because it allows a fudge factor in case the case gets moved up. So preserved skeletal muscle mass leads to significantly reduced postoperative hospital stay. I mean, that's amazing, right? And trend towards earlier return of gut function. Whole body protein balance and the suppressive, so it decreases insulin resistance, which is also interesting because your body, as you use up your glycogen, becomes insulin resistant on purpose to preserve your glucose, which ironically leads to higher blood sugars. So you're fasting, you become insulin resistant, and you have a higher fasting blood sugar, which is not good for surgical site infection and various other endpoints. But more importantly, the patient doesn't feel assaulted. Let's say patient scheduled for a 10 a.m. arthroplasty with Dr. McInerney, and there's an add-on urgent, and it turns into 3 p.m. So now the patient's NPO from the night before, and they're feeling assaulted by us, say, you're starving me. This can't be good. And they have every right to say that. Now, if they had a Gatorade the morning of surgery, they're going to have a completely different mindset. So what do we use? A Gatorade would be great, but even better than that is this Ensure drink called pre-surgery. It has maltodextrin, which is the carbohydrate used in the studies. It's cheap, and it's half the volume of Gatorade. So you get 50 grams in this 10 fluid ounce. And we give this out to our GYN patients at our PAT visits. So hopefully this will extend in the future across all services. Plus it has zinc and selenium in it, and the patients feel like, oh, this is a tonic that's going to make me do better. And so it's an intervention that they can partake in for a better outcome. So when do you admit it? Truth is, your body habitus doesn't predict gastric emptying. So here's a couple studies that showed that gastric emptying is not prolonged in obese patients. So it's reasonable to use it in your bariatric programs. But patients with diabetic neuropathy, so if they have diabetic neuropathy, it probably also systemically affects their gastric emptying. So basically, you see a patient with acanthosis nigrans and skin tags, and you know they've been hyperinsulinemic for years. Those are patients more likely to have delayed gastric emptying. So clinical judgment, it's hard to give a blanket rule for this. I just want to point out real quick, when you do your pain consults, that there is an inpatient pain management protocol in Cerner. And you're on your pain consult, you're on the floor, and now you got to search for CELEBREX, you got to search for ibuprofen, you got to search for OXYCONTIN. No, not anymore. Go to the inpatient pain management protocol, choose the type category patient you have, say frail elderly in this case. Choose CELEBREX, Tylenol, Tramadol, Flexeril, an analgesic balm, lidocaine patch, and sign, and go back to your day. So this is the inpatient pain management protocol in Cerner. It's available to you right now. And I think it'll make your life a lot easier because you won't have to choose the dose, the how often to give it, how to make it expire. And plus it offers the patient things you may not have thought of, like for instance, the analgesic balm. So that's like your Icy Hot or your Bengay. It's like $2 a tube. You put it on where the pain is. And although you only get a 5% drug level in systemically, you get 100% the blood level in the tissue where you put it on that you would got it if you took an oral analgesic. I'm sorry, I'm referring to diclofenac. So diclofenac, you get that 5% blood level and 100% tissue level. So diclofenac, which is a non-steroidal, is great for someone who wouldn't do well with a systemic non-steroidal. The analgesic balm is there for you to feel the menthol in the product, and the afferent pain signals that you were feeling, you no longer feel because you feel that menthol. So the analgesic balm or the diclofenac. Now the diclofenac gel is a little bit expensive, so use it sparingly. It could be like $40 a tube. But in a patient who's not appropriate for systemic NSAIDs, that might be the way to go. This is just a deeper dive into the protocol if you want to take a look at these slides later. That's all I'm going to discuss today. So basically, to summarize, any painful surgery for your patients, get some preoperative meds in them in the holding area, little sip of water, 3 Tylenol, 400 CELEBREX, plus or minus gabapentinoid in the right patient. Utilize dexamethasone for pain and peripheral nerve blocks. All right. This is good seeing you all. Have a great day.